I'm Eric Austin. I'm the director of the Pulmonary Vascular Disease Program at the Vanderbilt Children's Hospital here in Nashville, Tennessee. Today I'd like to go a little bit deeper into screening for pulmonary hypertension and early diagnosis with a focus on individuals who have lung disease associated with prematurity or other conditions of childhood. Two obvious areas that we'll expand upon in the rest of our discussion here would be genetic testing and the use of an echocardiogram and/or electrocardiogram. So let's think about high-risk groups that we might apply these technologies to. I like to think about different organ systems are involved that would put people at risk and also different points in people's lifetime. So I'm a pediatric pulmonary hypertension doctor and pulmonologist, and so one of the things that I think a lot about is developmental lung diseases. These could include congenital diaphragmatic hernia, alveolar capillary dysplasia with or without misalignment of the pulmonary veins, lung hypoplasia or underdevelopment, surfactant protein abnormalities, abnormalities of the pulmonary alveolar function, including pulmonary alveolar proteinosis, and pulmonary lymphatic problems. All of these conditions could be associated with pulmonary hypertension at some point in their development or expression, or even after they've been dealt with. You can see pulmonary hypertension emerge if they've not been completely handled. A reasonable approach, if you have a person who has one of these diagnoses, and especially if they have a diagnosis of prematurity, which we'll touch on even more, would be to get an echocardiogram and probably a BNP, which is a brain natriuretic peptide, or an NT-proBNP level at the time that you first determine that the individual has some sort of lung disease that concerns you. So at the time of diagnosis, for example, of congenital diaphragmatic hernia, that actually often occurs in utero before birth, but at the time of birth, we usually very quickly perform an echocardiogram of those individuals because almost all of them by definition have pulmonary hypertension at the time of birth, but we also want to watch them over time. So I think about not just an initial screening, but also a serial screening as clinically indicated, and at the bare minimum for a person who has, for example, lung hypoplasia or congenital diaphragmatic hernia that's been dealt with and has been felt to be under control, we would do serial screening for pulmonary hypertension every 1 to 2 years, and then of course as clinically indicated if they have a profound illness or a setback that would suggest that they have pulmonary hypertension developing. I touched on it earlier, but really a very large group at risk of pulmonary hypertension relative to the rare disease that we're talking about would be those individuals born prematurely. And there have been a number of recent studies to think about the premature infant and their risk of the development of pulmonary hypertension. For example, Pete Morani and colleagues at the University of Colorado, Steve Abman, Dunbar Ivy, and others embarked on a study not long ago in which they looked at 316 individuals enrolled in a study of prematurity and pulmonary hypertension, and they focused on people born less than 34 weeks gestation and also between 500 and 1,250 grams at the time of birth. So we're talking pretty small kids. What they did is they performed echoes at 7 days of age, and then they performed echoes at 36 weeks predicted postmenstrual age. So these would be if you're born at, say, 24 weeks gestation, you would get an echocardiogram at 7 days of age or 1 week, and then you would get an echo at 12 weeks later, which was 36 weeks postmenstrual age, we call it. And the investigators at the University of Colorado, who also worked with a group in Indiana University, Riley Children's, found that of the 316 patients enrolled at 7 days of age, 42% actually had pulmonary hypertension versus 58% without pulmonary hypertension. So as you can see, a really large degree of individuals using echocardiogram criteria had evidence of pulmonary hypertension at 7 days of life. Intriguingly, if you followed those children out, about 80% of the children with pulmonary hypertension at 1 week of age had no pulmonary hypertension by the time they were 36 weeks. Of course, that means about 20% still had pulmonary hypertension at 36 weeks. In contrast, about 10% of the kids who had no pulmonary hypertension at 7 days subsequently had pulmonary hypertension at 36 weeks postmenstrual age. And 36 weeks was chosen because that's a common time at which we determine there's a diagnosis of the presence or absence of a concurrent condition called bronchopulmonary dysplasia, or BPD, which is lung disease of prematurity, essentially. Well, what was interesting about that study, in addition to what I told you, was that for those babies who had BPD or bronchopulmonary dysplasia present and felt to be severe based upon a series of criteria that have been previously agreed upon, 30% of those patients, and there were 65 children in that category, had the presence of pulmonary hypertension by echocardiogram at 36 weeks. So what that tells us is what we already anticipated, is that those individuals with the most severity of lung disease born premature birth are at the highest risk of developing pulmonary hypertension. So you can imagine a concept in which you would want to focus your early echocardiographic analysis of the formerly premature infant on those people felt to have severe lung disease following delivery. So one way to think about diagnosing pulmonary hypertension or screening for pulmonary hypertension among those who have premature lung disease would be to say, okay, at 36 weeks, we're either going to screen all of our patients for pulmonary hypertension, no matter what their condition is, or we're going to take a severity basis approach. We're going to look at how much oxygen do they need, how poor is their growth, what are the concurrent conditions they're struggling with, do they have an atrial septal defect, have they had intraventricular hemorrhage, or have they had illness of their bowels. So there's a variety of ways that you can think about how to approach BPD screening for pulmonary hypertension. But no matter what you do, you got to know that about 12 to 28% of people who have BPD at 36 weeks are going to get diagnosed with pulmonary hypertension. And if you're a severe BPD patient, you're along that 28 to 30% range, much more likely. So what we do at Vanderbilt, and most people I think do nationally right now, is for those individuals who are infants with established BPD in the NICUs, or even those who have gone home, we obtain serial echocardiograms with or without BNP measures every 4 to 6 months, and then on an as-needed basis. Now, the caveats to that are that you need to be careful because the echocardiogram, as we mentioned earlier, is a non-invasive study, and so it may underestimate the presence of pH. And there's also times when it's overestimating the presence of pulmonary hypertension. So I like to add an electrocardiogram if I have any degree of confusion. And of course, we certainly consider the need for cardiac catheterization in each individual diagnosed with pulmonary hypertension. In the pediatric population, there may be times that we feel the risk of cardiac catheterization for the BPD infant does not outweigh the benefit, and so we weigh each of those cases very carefully. The other thing to keep in mind is that some children will look, quote, normal by echocardiogram when they're, quote, healthy, but then can have a profound setback at the time of a respiratory illness, such as bronchiolitis or other respiratory condition. It is important to remember that there are individuals born prematurely who are never diagnosed with BPD or bronchopulmonary dysplasia. In that setting, we're certainly a little less likely to screen by echocardiogram for pulmonary hypertension, but in general, we typically do screen all individuals at our institution, whether or not they have the diagnosis of BPD, with a screening echocardiogram at 36 weeks postmenstrual age, and then we consider its repeat of echocardiogram as clinically indicated over time. When you think about the at-risk individual, there are other conditions that certainly we want to think about, and we'll discuss several of those right now. One of those would include the population of individuals who have chronic hemolytic anemias. The most common example would be the sickle cell lung disease population. While there's limited pediatric evidence to determine exactly when you would approach screening for those individuals, we generally recommend a screening echocardiogram at 8 years of age, and then every 1 to 2 years thereafter and as needed clinically. For the individual who has a diagnosis in pediatrics of HHT, or hereditary hemorrhagic telangiectasia, you're probably aware that they associate with gene mutations in either the ALK1 or ACVRL1 gene or in the endoglin gene. And then for those individuals, we see those people in our pulmonary vascular disease clinic when they do not have a diagnosis of pulmonary hypertension on a yearly basis, and we obtain echocardiograms on a yearly basis at that time. We certainly also see them as needed and will have a low threshold to obtain an echocardiogram should there be challenges, because we know that HHT associates with pulmonary arterial hypertension in a minority of cases. Down syndrome is a large burden of challenge in our pediatric pulmonary hypertension clinics because these children are at more risk to develop pulmonary hypertension than the average individual, particularly those children who have had Down syndrome associated with congenital heart disease or Down syndrome associated with sleep disturbances. We're very aggressive about screening echocardiograms in those individuals. But if you have an individual who's had Down syndrome and done well, thankfully, over time and not required a large amount of intensive medical care, when they come to us at some point in their childhood, I will get a screening echocardiogram at 8 years of age if they've not had one previously. However, if they have sleep disordered breathing and have not had an echocardiogram already, I will obtain an echocardiogram in those children. And of course, those children who have had congenital heart disease will have had echocardiograms all along, but if it's a remote repair of a congenital heart disease in a patient with Down syndrome with, say, for example, a congenital heart disease repaired at age 4 and not been well integrated into the medical community after that, I'll obtain an echocardiogram again at 8 years of age, function than as needed. One of the other populations we'll see pulmonary vascular disease in is those individuals who have liver disease. And in that circumstance, we'll recommend a screening echocardiogram at the time of diagnosis of their liver disease and at the time of their liver transplant evaluation, as well as a yearly screening for those individuals who are struggling in any way. Certainly, we're worried about not only portopulmonary hypertension in those children, but also hepatopulmonary syndrome, which are two different conditions of pulmonary vascular disease in the pediatric and adult populations of people who have liver disease. Finally, in pediatrics, we don't have a lot of connective tissue disease associated pulmonary hypertension, fortunately. Although in our older children, we do see it, and certainly, as you know, in the adult population, there's a lot of connective tissue associated pulmonary hypertension. So for the children of connective tissue disease, we recommend a yearly screening echocardiogram to occur at the time of diagnosis and then once a year thereafter, and obtain a BNP plus minus an echocardiogram as clinical conditions dictate. The other thing to keep in mind, and is an additional study that I find helpful for children who are worried about pulmonary vascular disease, and if they're able to do it, I like to obtain lung volumes and DLCO at the time of diagnosis and on a yearly basis, at least for our connective tissue disease and chronic hemolytic anemia patients, as well as our liver disease individuals. My name is Eric Austin, and I'm aware that I'm rare.